Okay. Okay. So my topic of the day today is improving care for H. pylori infections. Later on in my talk, I will be concentrating on the use of Vonoprazan. I think we have gone through all these questions already. Actually, today's talk is more about we need to understand that H. pylori is a type of infections. And of late, if you look into a lot of guidelines published internationally, you can notice that they keep on mentioning about increased rate of antimicrobial resistance, and this has led to a lot of treatment regimes failure with lower eradication rates. And this is all because of a widespread and improper use of antibiotics. And most importantly, clarithromycin is one of the backbone of H. pylori eradications. So if we have a high resistance rate towards clarithromycin, then this will be severely impact on our efficacy of our treatment regimens. And if you look into all the international guidelines, if you follow up all these guidelines from the 90s until now in the year 2020, you can notice that they are proposing to use more types of antibiotics for eradications, and in fact also use longer treatment durations. Previously in the 90s, they proposed to use around 7 days, but nowadays everyone is moving toward 10 to 14 days. And the concern about the use of a lot of antibiotics in the H. pylori treatment is whether it will increase in the future antimicrobial resistance. And in fact, the similar concern was raised in the Taipei Global Consensus on Helicobacter eradications and stomach cancer preventions. So all the experts agree that the usage of various antibiotics in H. pylori treatment may lead to antibiotic resistance. And we have to understand that H. pylori treatment itself is not a simple treatment, and the treatment itself can be very complicated than other common infections. And besides that, even though we can test the sensitivities of the bacteria, however, clinically the response rates may not be as good as predicted. And this is because our stomach is a very hostile environment towards the antibiotics, not towards the H. pylori. And the antibiotics that will be used in the treatment of H. pylori, actually, they require a neutral or near neutral environment to be effective. Later, which I'm going to explain further. And way back around 10 years ago, one of the private doctors has voiced a concern about the efficacy of a clarithromycin-based triple therapy in eradications of H. pylori in Malaysia. In his series of patients, we noticed that actually his eradication rate actually is very low, which is around 55%. In terms of antimicrobial, in terms of treatments of infections, as long as the rate is less than 85%, it's considered as not satisfactory. But whether or not we still can use triple therapy in Malaysia, so we're going to discuss and show further today. So a bit about epidemiology of H. pylori in Malaysia. So this type of infection is typically acquired during childhood. So we believe that the infection is acquired during the childhood. However, it only manifests itself when someone is attained in the late 20s or 30s or even older. And the manners of acquiring is either through fecal oral or oral route. And what's the risk factor towards these infections? Most of the time is in the population of a lower socioeconomic status. And if the patient has more siblings, it also increase the chances of acquiring the infections. And most importantly, if the patient has an infected mother, actually this is the risk factor. So I think this is because the mother is the one that handling our food, especially when we are younger. So maybe this is the way that this infection has been perpetrated in the family or in a family or a familial cluster. Besides that, I think men is always explore around, always go and eat outside. So maybe this is the reason why men is slightly more affected compared to women. So if we look under the electronic microscope, actually the bacteria exists in a various format, either U form, V form, but the most commonest form is the spiral form, which is the infective manner of the bacteria. And the other one that is more, the other form which is very important is the coccoid form, because coccoid form is the one that can make the bacteria resistant towards the bacteria, because the coccoid form is a dormant form of the bacteria. So if you talk about the prevalence rates of H. pylori in Malaysia, it actually has been reduced for the past 30 years. For initially of half of the populations, now maybe it's around 10% of the population. But in terms of the race profile, the commonest race is still among the Indians. If you can see here, maybe 1 in 5 of Indians will be affected by the H. pylori infections. And compared to Chinese and Malay, Chinese maybe around 1 in 10, and Malay is maybe around 1 in 20. So if we look into the treatment guidelines for H. pylori, so what had changed over the years? So we can see that the first famous guideline actually was published in 1997. And currently the latest guideline is version 5, which is just around 4 years ago. So what has changed? So the guideline actually had proposed for the standard triple therapy, the clarithromycin, amoxicillin, triple therapy, they have converted to a bismuth-based quadruple therapy or bismuth-based triple therapy. And besides that, the treatment duration has become even longer. The first introduced was only around 7 days, and then subsequently they have proposed to lengthen the treatment duration to around 14 days. And besides that, a lot of other antibiotics has been introduced into the treatment regimens. And in these guidelines also, they propose that the clarithromycin-based standard triple therapy that we use a lot in Malaysia should be abandoned if the clarithromycin resistance rate in the country or the locality is more than 15%. And they propose that bismuth-based quadruple therapy should be used as first line. And just illustrated here is the various first-line treatment therapies for H. pylori. The commonest used among the local gastroenterologists is still the clarithromycin-based triple therapy. Other treatments regimen is not that popular because bismuth-based quadruple therapy, clarithromycin-based concomitant or high sequential therapy. Actually, this sort of regimen, I don't use it a lot because it's quite cumbersome. My favorite second line for eradication actually is levofloxacin-based triple therapy. And if you look into the Malaysian guidelines for treatment of H. pylori, actually there's only 2 published guidelines. The first guideline was published in 1998 by a group of gastroenterologists. However, this guideline is outdated already, more than 20 years. Also should not be used already because they propose metronidazole-based regimen with a treatment duration of a week. In contrast, the National Antimicrobial Guidelines, which I think they interpret from the guidelines from abroad, they propose the standard triple therapy. And however, they also propose bismuth-based quadruple therapy. Personally, I don't really agree to this BQT treatment because it uses metronidazole, and we know the local resistance rates towards metronidazole fragile actually is quite high. And if you look into the list of treatment regimen has been used in Malaysia, so it was published as early as 1994. At that time, they used omeprazole with amoxicillin or omeprazole amoxicillin with metronidazole. As you can see here, that if you look into the publication more than 20-30 years ago, they used a 1-week therapy. Nowadays, I think we should use a standard triple therapy of around 14 days. We can see here the eradication rate actually is very good, which is around 89%. Why this particular row here is in orange color? Because this is one of the publications that is just published recently in a group of Parkinsonism patients. Surprisingly, they still use a 1-week treatment duration. But you can see here that if you use a 1-week standard treatment regimen, the eradication rate actually is not good. It's only 81%. And besides that, we also need to look here that the dosage of omeprazole used, maybe they should use 40 milligram instead. So in terms of treatment in Malaysia, I believe that standard triple therapy, clarithromycin, amoxicillin-based treatment still can be used in Malaysia. However, you need to tell your doctors that the treatment duration actually is 14 days. And regarding third statement, high-dose amoxicillin-based dual therapy. So this second row here, you can see there's one publication that look into the use of PPI and high-dose amoxicillin, which is 1 gram QID, total of amoxicillin of 4 gram a day. So if you want to use a dual therapy, you should use a very high dose of amoxicillin, which is at least a 3 gram of amoxicillin. Then you can achieve an eradication rate of around more than 90%. Then we look into the antimicrobial resistance rate in Malaysia. So before we move to Malaysia, then we look into the global occurrence. So we can notice here globally, there's an increased resistance rate towards clarithromycin, metronidazole, and levofloxacin. Since in 2011, so there's a lot of publication that looking into the clarithromycin and metronidazole resistance rate in Malaysia. Before we embark on the last row here, we can notice that actually the antibiotic resistance rate in Malaysia generally actually is quite low, which is less than 15%. Except for one recent publication from Kuala Lumpur. Actually, all these publications is all published in Klang Valley, not in other states of Malaysia, all originated from Klang Valley. So they notice here that the Cheras location actually is around 36%. Metronidazole actually is also quite high, around 60%. And my favorite second line is around 25%. So I think we need more local data on the resistance rates, especially on clarithromycin, because this is the only single study that published a very high figure, which is more than 15%. So we move on further on why we need a proper acid suppression in Helicobacter eradication, because the acid suppression actually is very important strategy. Because H. pylori itself actually is very difficult to treat because it lives in a very hostile environment, which we have a pH of ranging from 1 to 3.5. And this bacteria actually doesn't reside only inside the stomach, it also resides inside the acidic mucus, the epithelial cells, and deep inside the in between the epithelial cell lining. And even though we know that stomach, when it's in a full capacity, is as large as a basketball, however, the various locations inside the stomach actually has various pH compositions. And this also change with the patients when they are eating their food as well. And we also know that in a very acidic environment, the bacteria actually lie domains. They only replicate when the pH is around 6 to 7. This is the reason why, if you look into these slides here, for amoxicillin or clarithromycin, if the bacteria tend to be resistant towards the bacteria when the pH is lower than 6, okay? But if we manage to bring up the pH further to more than 6 or 7, actually we can notice that the bacteria start to become more sensitive toward clarithromycin or amoxicillin. This is because the antibiotic needs the bacteria to replicate, then only they will work better. If they are not replicating, it will render the antibiotic to be useless. Talking about pH is the reason why gastroenterologists or surgeons like to have a good acid suppression when the patient has upper GI bleeding, because we need a high pH or at least more than 4. Because when the pH is more than 4, there will be better stabilities in terms of the clot inside the stomach, and that also will improve the ulcer healing. So the important role of acid suppression or PPI actually is to bring up the pH so that the bacteria replicates, and besides that, that also can cause stabilizations of IgAs, immunoglobulin. So this slide basically shows the various antibiotic degradation rate in the various pH. We can notice that in the pH it's become more alkaline. The degradation constant actually becomes stabilizers. And when we compare the concentrations of the antibiotic remaining at the pH 7 when the patient is on PPI, or in a very acidic environment, you can notice here that the concentrations of amoxicillin and clarithromycin actually is higher. This is the thing that why we need to have a good acid suppression. And before I embark further, so I just need to bring to your attention regarding the CYP2C19 polymorphism's influence on the concentrations of our proton pump inhibitor. If the patient is a fast metabolizer, actually it will reduce the concentrations of PPI in the blood. So it will render the pH to become lower instead of a pH of 6. And up to 25% of the Asians are actually fast metabolizer. That's why you can see in some of the treatment regimen, they propose a higher dose of a proton pump inhibitor, not 20 milligram, or instead of 14 milligram of omeprazole. And we know that there are certain PPIs that is less influenced by CYP2C19 polymorphism, which is the Dexilant, esomeprazole, and the rapiprazole. So what is the new development in the better acid control? Because acid control is very important not only for H. pylori treatments, also for treatment of reflux disease. And one of the regulations from the treatment actually is the Vonoprazan. And it is marketed in Japan since in the early 2015s. And it has gained a lot of popularity because it has superior properties in rapid acid control, because they have a very fast onset and longer duration of suppressions. And it doesn't be influenced by the CYP2C polymorphism. And because of this Vonoprazan is a very good acid suppression. These slides basically just illustrate the mechanism of actions of lansoprazole. We know that it is converted to active form by acid. So PPI actually need acid to convert into an acid form. This is a reason why we always ask the patient to take the meal roughly around 30 minutes to half an hour before taking PPIs. Even though taking PPI after meal is still have some effect, but the acid suppression effect is not as good because the PPI need to be converted into active form and they need acid itself to act. Compared to Vonoprazan, it does not need to, it can consume Vonoprazan anytime. And besides that, it doesn't require to be activated. It will straight away become an active form as shown in this slide. So immediately after consumptions of Vonoprazan, it will reach optimal concentration in the blood circulations and inside the stomach as well. And the effect actually is more stabilized compared to PPI. So usually when I start PPIs, I will tell the patient that you may only see the effect after 3 or 4 days. You may see the effect only after 3 or 4 days. So if you are required to have a maximum rapid onset acid suppressions, so Vonoprazan maybe is the best options. So after the few doses of PPI, then only you can see the effect is there. So this is the reason why that for a certain patient who has very irregular working hours, those who in the shift work, most of the time for this group of specialized patient, I would prefer to use a PCAT instead of a usual PPI. Instead of this slides basically just looking into the thing that I mentioned earlier. So we can notice that here they compare the concentrations of Vonoprazan before and after meal. You can see that actually there is no much of differences. So it works in whether the patient taking before or after meal. And besides that, if you look into the maximal acid suppression profile, actually Vonoprazan acts better than the esomeprazole. You can see here that Vonoprazan managed to reach a higher acid suppression at a pH of at least more than 6 higher compared to esomeprazole. This slide also illustrates the same things as well. So if you look into the pharmacological comparison between the PPI and the PCAT, actually we can see here that PCAT doesn't require acid suppressions. It is already an active form by itself, and it's a very active, so it's very stable in terms in the acidic environment, and it doesn't be influenced by the CYP2C19 regimen. Because nowadays, there is still some doctors is concerned about the interactions towards PPI and the antiplatelet, which is the Plavix. Some of my colleagues, they are still very concerned about it. So they try or prefer not to use things like Nexium in a patient who's also taking concomitant clopidogrel. And most importantly, Vonoprazan was not influenced by meal at all. Okay, so it doesn't influence by the meal at all, and it has a massive immediate acid suppression just within 1 hour. Okay. So come to the topic today. So will Vonoprazan introduce a new progress in the H. pylori eradication? Before we talk about that, so we look into the previous antibiotic regimen, because as I mentioned earlier, all the guidelines actually they propose to use a lot of drugs to treat H. pylori, at least 2 types of different antibiotics. So, and we also understand that from our own Malaysian data that basically there is no resistance towards amoxicillin. So is it possible that we use amoxicillin coupled with a good acid suppressor so that we can see whether it can achieve a good treatment response? Actually, there's a lot of publications since in the mid-1990s. So if we look into all the previous publication, actually the treatment response actually is not that great. All the eradication rates actually is less than 85%. And besides that, if you want to have a good response also, you need to use a very high dose of amoxicillin, which is at least 3 grams. So if you look into the earlier study, when they use 1.5 grams of amoxicillin a day, compared to the one other publications which use 3 grams of amoxicillin, you can notice that the eradication rate has improved from 42% to 70%. And maybe the other thing is the usage of older PPIs. This is things like omeprazole, lansoprazole, or pantoprazole. Actually, they are categorized as a first-generation PPIs. Period, esomeprazole and rabeprazole, they are classified as newer generations of PPI. But despite that usage of these newer generations of PPI, they still require a use of very high dose of amoxicillin to eradicate. We can notice here that with the use of a good acid suppressor and a high dose amoxicillin with a treatment durations of 14 days, we can achieve eradication rate of at least around 90%. I do use high dose in 1 or 2 patients myself, but I think you're aware that the use of amoxicillin actually that causes a lot of GI intolerance. Mainly the patient will complain of bloating and most importantly, uncomfortable diarrhea. So this is the reason why I'm quite refrain on using a very high dose of amoxicillin. So again, not good results, even though despite good acid suppressor, and because we need to use a very high dose of amoxicillin and with a very prolonged treatment durations. So can Vonoprazan or PCAT regularize this sort of use of a dual therapy? So actually can. So this is one of the publications that published in Japan just very recently that look into the use of a 7-day Vonoprazan with a lower dose of amoxicillin. What is low dose amoxicillin? They use Vonoprazan 20 milligram BD twice a day with only 1.5 gram of amoxicillin versus the standard treatment regimen that they use in Japan. Actually, it shows that for those patients that are using the high dose dual therapy, they have a non-inferior treatment response. So meaning that the treatment response is similar to the use of a standard regimen. Japan is a bit different from Malaysia because based on the research data from various locations in Japan, for Japan population, the use of 7 days of triple therapy actually is sufficient. But as I illustrated earlier on in my previous slides, if you use 7 days of standard therapy in Malaysia, the treatment response is not that great. It will be less than 80%. So in Malaysia, we had to use 14 days of standard triple therapy. So if we look into this result with the use of a good acid suppressor, which is the Vonoprazan, with a lower dose of PP, a lower dose of amoxicillin, actually we can achieve a good treatment response. So in conclusion, actually what's the benefit of Vonoprazan versus PPI in dual therapy? So one of the benefit is a minimal usage of antibiotic, and which is more simplified treatment. Because this is very important, because a lot of patients in regards to H. pylori treatment, they don't really like it because the treatment duration is very long. A lot of drug has been used, and a lot of my patients usually they comment the use of a lot of drugs. And with the use of Vonoprazan-based dual therapy, actually we can achieve a good treatment response. And Vonoprazan-based dual therapy may be a potential first-line treatment of H. pylori in Malaysia. So what has changed with the introductions of Vonoprazan? Because Vonoprazan is originate from Japan, and besides that, a lot of countries actually in the West, they are still or just started to use Vonoprazan. Actually, there is a very limited data if you look into the publications from the European countries or the Americans. Most of the publication for Vonoprazan actually originated in East Asia region. So if we look into over the years, what has changed in the Japanese guideline? So Japanese guidelines is published earlier in 2001. At the moment, for Japan population, in Japan, the standard triple therapy amoxicillin and clarithromycin is still usable in the 20 years ago. However, 20 years has passed. Actually, their resistance rates to clarithromycin actually has increased to around 40%. So they also propose that in Japan population, they should not be using standard triple therapy unless the patient has antibiotic susceptibility testing has been done. And besides that, they propose to use of Vonoprazan based or standard PPI based with amoxicillin and metronidazole based therapy. Again, I would like to caution the use of metronidazole in our local setting as the resistance rate is very high. So Japan is the only country that have put Vonoprazan-based eradication regimen into their guidelines. If you look into the other guidelines that is originate from America and European countries or Canada, they actually in terms of Vonoprazan, they are still awaiting for more study results. But for Asian population, maybe we should consider to use it. For myself, I have looked into my own series of Vonoprazan-based eradication, either first line or second line. Actually, the response rate actually is as high as around around 88%. So this is another segment on my presentation, which is towards a more personalized eradications. So we really need to look into our patient's profile. So, and we know that which I have already shown earlier, our local antibiotic resistant profile. So we really need to look into our clarithromycin resistance, because one publication in 2019 shows the eradication rate as high as around 36%. So we need more data from various locations in Malaysia, not only from Kuala Lumpur. And besides that, we may need to look into the genome sequencing of the H. pylori in the patients to look into their towards which particular antibiotic they are resistant to. The other thing is maybe we need to look into the CYP2C19 polymorphism of our local patients. So because if this patient is a fast metabolizer, we may need to consider to use a Vonoprazan-based therapy or a more higher dose of PPI, a more regular dose of a PPI instead of just a BD dosing. And besides that, we may need to look into culturing of the bacteria to see whether the patient has a coccoid form or H. pylori. Again, because H. pylori is a dormant form of which is also become resistant towards antibiotics. This is just to mention about one of the recent progress in China. So in China, actually, they have a national data on H. pylori antibiotic resistant profile. This is actually is an app on a handphone. Based on your locations, you can notice here, even though China is quite wide, but the main publication is actually is coming from the east coast of China. Then we can notice here that actually in terms of antibiotic resistant rate in China actually is quite high. Levofloxacin, which is maybe around 46%. Clarithromycin, which this is in the Guangdong province, levofloxacin 46%. Clarithromycin, which is around 60%. Similar to Malaysia, their amoxicillin resistant profile is still 0. This is one of the antibiotic which is I can't remember what's the full name already. And then, but the metronidazole resistance rate actually is very high, which is nearly around 100% in China. So in terms of conclusions, so there is a possible increasing trend of H. pylori antibiotic resistant profile in Malaysia. Acid suppression is very important for a successful eradication. That's why I always tell my patient, if you want to properly treat H. pylori, go for original PPI at least, or use a Vonoprazan-based regimen. So Vonoprazan may provide a new treatment direction in terms of treatment of eradication of H. pylori with a high-dose dual amoxicillin therapy. And we may need to look into personalizations of treatment in terms of H. pylori eradication. Okay, with that, I thank you for your kind attention.